Hello and welcome to another episode of Keeping London Healthy. My name is Dr. Mario Elia. Today we're going to be talking about all things pregnancy related with Dr. Genevieve Eastabrook from LHSC. She'll be answering all our questions about pre-pregnancy, pregnancy, and kind of post-pregnancy planning. So we'll be joined by Dr. Eastabrook right after this message. All right, welcome back. And again, we're excited to be joined today by Dr. Genevieve Eastabrook. Dr. Eastabrook is an associate professor of obstetrics and gynecology at London Health Sciences Center, and she's a maternal fetal medicine subspecialist. So thanks again for joining us today.
Well, thank you for the invitation. I've been really excited about this.
I mentioned to you offline, this is an episode we've gotten a lot of requests for, a lot of patients anticipating pregnancy who are pregnant, and there's a lot of questions that come up frequently. So we thought we'd hit a lot of these today. So let's start, I guess, with pre-pregnancy planning. So a patient who's considering becoming pregnant, what are things they should be doing or not doing? Anything they should be taking? What kind of things should patients know as they're planning or contemplating pregnancy?
Well, first of all, I think it's great that people are thinking about planning and contemplating pregnancy, because more than half of pregnancies are actually unplanned. And so the best time to be thinking about pregnancy is before you actually are. Some of the big things are just general health maintenance. So making sure that you're up to date on your typical health examinations, things like pap smears and STI screening. But also making sure that you're taking preconceptual folic acid, which is really important for prevention of neural tube defects or spina bifida. And so people who are anticipating a pregnancy or trying to conceive should be taking 0.4 to 1 milligrams of folic acid. And that can either be taken as a standalone supplement or as part of a multivitamin or even a prenatal vitamin. Some people will start to take that prior to it, but that's really the key thing. The other things are just some general health maintenance things, such as quitting smoking, quitting cannabis, and minimizing the use of alcohol. Obviously you don't want to be using alcohol when you're pregnant, and because some people don't know, when exactly they become pregnant, it's important to, at least limit that in the time that you're trying to conceive. And then one of the other things is that if you're taking medications for particular health conditions, it's good to be able to talk to your primary care provider or your specialist about which medications are safe to take in pregnancy and which ones might have to be switched to something more pregnancy friendly. And I think one of the big things is that actually most medications are okay to take in pregnancy. People have a lot of concerns about things such as antidepressants, but most medications that are optimizing your overall health and well-being are actually important in terms of risk benefit kind of balance. But it's good to have a conversation before you're trying to conceive about any medication questions or choices that you have.
I'm glad you touched on the folic acid and the alcohol too. Obviously, in pregnancy, we recommend zero alcohol to patients. Common question that comes up when someone has a pregnancy that was not intended, and they come in having had maybe a small amount of alcohol in the month prior. What do you generally tell those patients in terms of reassurance? I know sometimes people are worried whether they've caused any harm. What's your general advice to them?
I typically tend to be very reassuring. Very early in pregnancy, most exposures are kind of an all or nothing phenomenon. So if you have a particularly toxic exposure to something, oftentimes that's not compatible with an ongoing pregnancy. And then the other thing is the placenta doesn't form right away, and so there's less transfer of toxic exposures like alcohol very early in pregnancy. So, people shouldn't panic if they, had a positive pregnancy test and, had a couple of beverages beforehand, because in most cases, that's really a very early and not a harmful exposure.
Patients will often ask, who are, again, planning pregnancy, trying to get pregnant, how often should they be having, intercourse to maximize their chance of becoming pregnant? And what time during their cycle should they be trying? And ovulation trackers? What advice can you give the patients there?
Yeah, I think for some people, trying to conceive can actually be a really stressful time, particularly if you are dealing with, infertility or subfertility. And there's a lot of advice out there from different groups, and you'll get lots of advice from perfect strangers as well. The most sort of solid guidance that I could find was actually from the Canadian Fertility and Andrology Society. And they suggest that, if you're having a menstrual cycle that's relatively regular, so meaning, you're having a menstrual cycle every 25 to 35 days, that most likely you are ovulating. And so they don't actually endorse using ovulation prediction kits, if there are regular cycles, and then also symptoms to suggest ovulation. Some people will get some pain or bloating at mid-cycle, and then, your typical premenstrual type symptoms. In terms of sort of timing of conception, that can be a little bit more tricky, because, a lot of people have this idea that, your menstrual cycle is 28 days. And so day 14 is when you ovulate, but actually most people don't have a cycle that matches that. If you have a longer cycle, for instance, you may ovulate later. So I think the key thing is around the mid-cycle time, to be planning to have intercourse, usually sort of 2 to 3 times per week, or sort of every second day during that time. And so that's sort of the best guidance that I could find, in terms of, at least when you're starting out trying to conceive. There's lots of other methods like basal body temperature testing and whatnot. And again, that's not recommended for kind of a low risk trying to conceive population.
So if someone's been trying to conceive, having difficulties, when should they be reaching out to their healthcare provider?
Yeah, so some of that depends on your age. Some of that depends on any other underlying health conditions or concerns. So, I mean, we know that most people will conceive within a year to 18 months of actively trying to conceive. So about 20% of people will conceive each month that they try. So, the guidance typically is that if you have been actively trying to conceive for a year, and haven't become pregnant, then that's probably a time that it would be flagged that there should be some investigations done. Now, that being said, is if you're over age 35, if you have an increased BMI, over 30, or have underlying health conditions like diabetes, or irregular cycles, that guidance may be different, and we may suggest even 6 months of trying to conceive, and then potentially a workup, or if there are concerns with irregular bleeding, or other issues.
So for someone who trying to get pregnant gets their first positive pregnancy test, I hear from patients often that they'll often do 4, 6, 10 tests to confirm that it's positive. Any benefit beyond doing that first one to make sure it's not a false positive, or do you find they're fairly reliable?
I think, if it's positive, it's fairly reliable, as long as you're following the instructions, because sometimes you can have a test where if you leave it sitting for too long, for instance, you can have what's called an evaporation false positive. But particularly if you're having symptoms to suggest, early pregnancy, nausea, breast tenderness, and there has been a missed period, if the pregnancy test is positive, then it's unlikely to be a false positive. But certainly then it's good to, see your primary care provider for confirmation of the pregnancy, and to get the ball rolling in terms of your antenatal care.
For sure. And often, obviously, but when someone finds out they're pregnant, calling their doctor right away. I've had some patients kind of put that off. The latest one I ever had was 24 weeks. She decided to call me at 24 weeks that she was pregnant. So definitely calling your primary care provider when you know. And then now, what kind of tests will your primary care provider be arranging at that first visit? So you go there, find out you're pregnant, want to move forward with the pregnancy. What kind of tests should people expect to be ordered?
Everybody should be offered kind of what we call routine antenatal serologies and pregnancy screening. And that includes some very basic things, like a complete blood count. So to check for things like anemia and platelet count. But, we also want to make sure that we know your blood group and type, particularly if you are Rh negative, because if there is any bleeding in early pregnancy, and then also for later in pregnancy, it's important that people get their Rh immune globulin injection. And then we screen for a number of serologies, both to test for immunity to particular infections that may be important in pregnancy, and also for exposure to infections that may be important to either monitor or treat during pregnancy. And so that includes things like syphilis, HIV, hepatitis B. In some populations, we're also screening for hepatitis C, and that may actually come about as a routine screen in Ontario eventually. And then also screening for immunity to rubella as well, because although that's not something that we would vaccinate for during pregnancy, it's important to know whether or not you're immune, and then we would vaccinate postpartum for that. So those are some of the sort of the basic things that we would start with. Depending on risk factors, cycle regularity, and availability, then we would often book people for a dating ultrasound as well to confirm our dates most accurately. The way that the SOGC recommends now that we date pregnancy, so basically establishing the due date, is with a first trimester ultrasound, because we know that that's much more accurate than the first day of the last menstrual period. Because as we talked about, people don't necessarily have a regular 28-day cycle, and that's what pregnancy dating by LMP is based on.
And we'll take a quick break and be back right after this message. All right, and we're back with Dr. Eastabrook, answering all of our questions about pregnancy. Question that pregnant patients will be asked and offered is screening for conditions like Down syndrome and spina bifida. And this is often kind of a complicated conversation we have with patients. But to give patients kind of a sense of what's available, kind of what questions they'll be asked, can you give a sense of kind of what testing is available, both covered by OHIP and not covered by OHIP?
Yeah, so that's a really important question. So I always tell my own patients, and also anybody that I'm educating, in terms of medical students, residents, that everybody should be offered screening for Down syndrome in pregnancy. And that's whether or not, they, would manage the pregnancy differently, whether or not, there was a positive screen. But I think the key thing is really to explain that, it's a screening test. And so there may be a result that's positive or negative, but it doesn't necessarily mean that the pregnancy is impacted. There's no risk to the pregnancy with doing it. If we're doing what's called extended first trimester screening in Ontario, it's a little bit different than some other provinces, because we do an 11 to 14 week ultrasound for nuchal translucency, as well as a combination of it's a blood markers based on the placenta, and that's basically integrated into basically a risk assessment that includes also things like maternal age as well. So it will give you a positive or negative based on that, and we consider it a positive screen if it's more than 1 in 350. So that's what's offered to everybody. There's it's covered by OHIP, and everybody should have the opportunity to have that. Sometimes people will present later in pregnancy and they will miss the window for the nuchal translucency ultrasound, or just because of access, for instance, during the pandemic, or because they live in a region where ultrasound access may be more limited. We can also do what's called a maternal serum screen, which can be done between 15 and 20 plus 6, so 15 to 21 weeks roughly, and that's actually just the blood test to look at the placenta markers, and so that's another test that can be offered, and so people haven't necessarily missed the boat. So for patients that are at higher risk of Down syndrome, whether it's because they've had a positive EFTS, they may be age over 40 when they give birth, or they potentially have had a previously affected child, for instance, they actually can get what's called the non-invasive prenatal test, or NIPT. Some people call it NIPS because it's actually a screen. So there's lots of different names for it, and it's self-refuted DNA screening. So again, it's a blood test, no risk to the pregnancy, and it's slightly more accurate than the extended first trimester screen because it actually uses fragments of DNA that are in the maternal bloodstream that come from the placenta. So that's why it's still considered a screening test, because the cells don't come directly from the fetus, they come from the placenta. But that will tell us with more certainty. So if it comes back as negative, which is the result that you want, then there's a less than 1 in 10,000 chance of there being Down syndrome or some other common trisomies like trisomy 13, 18, and something called triploidy, where there's 3 copies of all of the chromosomes. The other important thing about that test is that we can also screen for fetal sex. And that's important for people, for instance, who might be a carrier of a sex-linked disorder. Now, the cell-free fetal DNA testing, or NIPT, is also offered to every twin pregnancy now. And that's something that's just come about in the last year or so in Ontario, because that's the most accurate way for us to screen for Down syndrome in twins. And so that's also OHIP funded. Now, on the other hand, if people want to do the NIPT because it's more accurate as a screening test than the EFTS and screens for more things, people can also choose to pay for it as a self-pay test. And it's available through several platforms and several labs. It still has to be ordered by a physician, but it can be a self-pay test as well with adequate counseling.
For those patients who are paying out of pocket for the NIPT and find it to be expensive, I know there are some American companies that do offer that testing at kind of a cheaper cost than our local labs. I'm not sure if that's something that you'll often offer to patients, or do you find it reliable to a few of the companies that in the States are doing that?
There's one company that I'm familiar with called Invitae, that is a validated platform. It is substantially cheaper than the tests offered through Life Labs and Dynacare. And so, I mean, it's still not inexpensive, but it's significantly less expensive. And that has been validated as a platform. On the other hand, there are some other ones that are available online, which I would caution people about. Things like, there's a company that's called, I think, Sneak Peek, where it actually claims to be able to tell you the sex of the baby, and it's like $75. But I've actually had a number of people who've had incorrect results with that.
Oh, wow.
So,
Yeah.
so
kind of a big deal.
I'm a little bit cautious about that one, and especially if there's really important decision making that you're having, you really want to use something that's well validated and recommended by a healthcare provider.
And back to the first trimester screening, so the blood work and ultrasound. So if a patient says that any result in that wouldn't necessarily affect their decision to move forward with the pregnancy, and they don't really care to know early on, and they're content to maybe find out later on an anatomy ultrasound, would those be patients who you would still find it useful to, as the obstetrician, to know that early on that there potentially is an issue with something like trisomy 21? Is it useful to you as a care provider later on, or is it something that really, if the patient doesn't care to know that, they may not necessarily need to pursue that?
It's something that I would offer to anybody, but some people will choose to decline. Some people would find it stressful, for instance, to have even a false positive result. I do encourage people to do it, even if they say, well, I wouldn't stop a pregnancy if my baby had trisomy 21 or something else going on, because it can be really important in terms of some additional screening we do during the pregnancy, and also where the baby is born, because there could be issues, for instance, with a congenital heart defect or issues with the gut. And so we really want to make sure that baby's born in the most appropriate place possible. And we know that people are much more equipped and bond better if they are prepared beforehand that their baby might have a problem.
In terms of decision making, in terms of, because obviously patients are given the choice of who to see, their family doctor, an OB, a midwife. Obviously, you and I might have our own I'll call them biases when it comes to this, but what kind of information should patients know when they're kind of making that decision? What should go into that decision making?
People living in Ontario, particularly Southwestern Ontario, are very lucky because they have access to several different models of care for their obstetric care. And so for low risk patients, they have the option of seeing either a midwife or a family physician who does obstetric care, or sometimes an OBGYN for low risk care. Midwifery is a different kind of a model of care than the physician-based model. And the nice thing about the midwifery model of care is that we can also still collaborate and share care with a physician-based model, particularly with an OBGYN. The other unique thing about a midwifery-based model, well, there's two things that are kind of unique to that model. One is that there is an option of a planned home birth with the midwifery-based model that is not available in the physician-based model in selectively screened patients. And then the other thing is that they also do home visits postpartum, and so they're able to come to the home for additional breastfeeding support and baby care, and they would look after the birthing person and then the baby for that kind of 6 weeks. Now, family practice OBs, we're very lucky in London because we have a fairly large group of family practice docs that are have extra training in obstetric care as well. And so they provide low risk obstetric care with birth based in the hospital. And then depending on what type of model they're in, they may only do the care for that pregnancy and then refer back to the patient's regular family doctor, or they may also have a continuity model where they actually will care for the birthing person and the baby for the rest of their lives. And so that's also a great model. The midwives and family practice doctors don't do operative vaginal deliveries, so things like forceps, and they don't do cesarean sections. And then they also would have to transfer care for particular medical conditions in pregnancy and for twin pregnancies. And then for OBGYNs, we cover the full scope of kind of, and I hate to label people as high risk, but higher risk pregnancies, where there may be, medical disorders complicating the pregnancy, fetal issues like, a small baby, or twins, and particularly more complicated twins or higher order multiples.
So we discussed ultrasounds there briefly. For patients, when should they be expecting to get ultrasounds done during the pregnancy, and when do they find out what the baby's body parts look like, and when do they find out baby sex? What are those kind of timelines through the pregnancy?
It varies a little bit depending on kind of risk factors for pregnancy and whatnot. Most people should be getting at least 2 ultrasounds during a pregnancy. The first would be that nuchal translucency ultrasound that's done in the sort of late first trimester as part of the Down syndrome screening. And that in many people also serves as their dating ultrasound as well, but some people may have an earlier ultrasound for dating of the pregnancy. And then the ultrasound that everybody should be offered is the 18 to 20 week ultrasound, and that's what we call the fetal anatomy survey. And that tells us a lot of really important information, which includes, screening for any fetal anomalies. So looking at baby from head to toe. That's also the time when people, if they want to find out the sex of the baby, would be able to find out that information. But it also tells us some other important things like the location of the placenta, to make sure that there's not something like a placenta previa where the placenta is covering the cervix or any other abnormalities with that.
Question that comes up from patients around a sugar drink test that they hear about, and they hear from friends that maybe this isn't the most fun test to take. What do patients need to know about this test?
So everybody is offered screening for gestational diabetes. Long ago, we used to screen only based on risk factors, but we realized with the changing obstetric population that everybody should be offered screening for gestational diabetes. And that's typically done between 24 to 28 weeks. And that's done with what's called an oral glucose tolerance test, which is I call it a medical grade orange juice. And so it's 50 grams of glucose in usually it's an orange, slightly fizzy drink that you drink, and after an hour have a blood test done. And there's particular cutoffs for diagnosis of gestational diabetes, or there's actually a cutoff for what we call just a positive screen. And then in that case, then you would move on and have what's called a 75-gram confirmatory oral glucose tolerance test. And that's a 2-hour test that's done from fasting. And so some people unfortunately have to go through the second test for confirmation to see whether or not they have gestational diabetes.
Thank you so much, Dr. Eastabrook, for taking the time to answer all of our questions today. I'm sure people watching at home have found this incredibly useful, both for patients planning pregnancy or in the midst of pregnancy. So again, thanks for joining us today.
Well, thank you. It's been a lot of fun.
And again, thanks to Dr. Eastabrook for answering all of our questions about pregnancy today. And I think I had so many more questions to ask her that we may need to bring her back next month. So keep an eye out for that episode next month. And until then, stay healthy.